So I'm going to be talking about cervical cancer today. And I'm Anuja Jhingran. I'm from MD Anderson Cancer Center in Houston, Texas. And what I've actually decided to do, and we're going to do the intro, if I can make this work. So we're going to cover cervical cancer, and we're actually only going to do intact cervix and brachytherapy. We're going to keep the post-op cervix cancer to next time when I do cervical cancer and endometrial cancer, because they have so many common things. So my understanding is that you guys have already learned how to do nodes. And just to start with, I know this was a question that you guys were asked last time. What is the correct way of contouring elective nodes? And interesting here. So, and I know you guys were asked this question last time, and just the answer was D, right? And why was it D? And this is important because as we go through this, then since I am not going to do nodes, but nodes are so important that I really want to make sure that we understand why not, right? A was because they just contoured the vessels, right? But not the space in between. The nodes occur in between the vessels, right? So here they're actually their contouring is missing areas where there could be nodes, especially posterior to the vessels right here. This one, it just was a little bit too tight, and this was just perfect, right? And this one's also covering all the sacral nodes, which this one is not, right? Just to make sure that we start with the basics, which is the nodes, which I am not going to be talking about. So let's first talk about contouring. So is contouring of the intact cervix easy? It's not. And I'm going to tell you that because I am going to go through the contouring, but I want to tell you that it is not easy, and never expect to be perfect at it. We actually did a study looking at contouring, and we did have endometrial element intact, and I'm just going to show you the intact. And these were actually experts throughout the world in their fields in GYN, and they were told to contour an intact cervix. And it was based on guidelines, and that we do definitely have guidelines, and I will send you references later, which I did not put in to my so I'm just going to let you guys know that I will send you some references later, or I'll have it on with my next talk. But this is one of really a good reference, but it is based on MRI. There are other references based on CT, and I will send you both of them. But we asked these experts, and these were experts in their fields, to contour an intact cervix. And it was an intact cervix with one positive node. And in fact, we're actually going to use the same sample size to contour. So I'm going to use this patient when we contour live, right? So I'm going to contour live, but it is an intact cervix with one positive node. Full and empty bladder scans were given, and we told them to do lymph nodes in cervix, uterus, and vagina, and then do the gross nodes. So as you can see, here is actually the contours from all these experts. You can see where the 50% line lies. But you can see so the green is the 50%. So the green is 50% of the people actually contoured this, right? 1% of the experts actually contoured a lot more into the bladder. And then 100% right here, and again, another 1% did really just the cervix. And we're going to talk about really what's the right and wrong about this, but just to show you, even among experts, it is really hard to contour an intact cervix. As you can see in the sagittal again, one person actually really did contour a lot more vagina and a lot more bladder, as well as rectum. Interestingly, that same person really contoured more of the nodal area, and we're not going to talk about that, but again, we could discuss this later on, and I may bring some of this back when I do endometrium. But it's just interesting to see, even amongst experts, there's a huge difference in contouring. And like I said, this is the exact case that we're going to contour live, so I will show it to you. But just showing you the difference in variations of different contours. So you can see, look, one person went really right into the bladder. Another person did even a bigger dip into the bladder. One person really just treated, you can see missing actually the uterus and the cervix right here, the blue, right? Because the green is your 50%. You can see that all the different contours. Even nodal contours were not the same. Sagittally, you can see key. We talked, and I think I'm gonna cover what to cover nodally on my next contour, but you can see one person went all the way up to the periortics, even though there was only one pelvic node that was positive. Another one went and covered most of the common iliacs, right? 50% though just went to the bifurcation. So even nodal coverage isn't consistent with the experts. And again, you can see the difference in contouring. Here's one person who went all the way into the bladder, another person who really treated all the way to the anus, right? So we'll discuss this, but you can see there's a lot of inconsistency. Nodally, so this was a one positive node, they actually did pretty well. So if you looked at the data, there was a lot of missing volume, there was a lot of extra volume, and you can see the contouring was all over the board. You're supposed to be 0.8 and above. Majority of the experts were actually below. So huge inconsistency. And again, it was both either right or left, craniocaudal or anterior posterior. So the conclusion of this is that despite consensus papers on how to contour, there's a huge variation on how to contour amongst even the experts in the field. So I want you to know that, and to know that it's okay to be wrong, and it's okay to have somebody re-look at your contours, because our answer was you really need to have other people look at your contours before you submit them for planning. Okay, so that's a key. It is important. All of my contours are always reviewed by somebody else before I even do my planning. And it's okay for me to change them, right? So I want you to know that it is really important to have somebody review your contours. So intact cervix, and like I said, we are going to do live demonstration, and we're actually going to use that case that I talked about. But first, we're going to ask some questions. So here's my first question. And are we ready to do the poll? So my first question is, for locally advanced cervical cancer, FIGO stage 2A, what is the correct way to extend CTV into the vagina for external beam contouring? The vagina should not be included in the CTV. Cover the upper 2 cms of the vagina, and if involved, extend 2 cms below the GTV. Cover down to the introitus. Cover the upper 1/2 of the vagina. So why don't we go ahead and get voting?
Great. Answers are coming in.
And it looks like we got pretty much all the answers. So should I end it, or you're going to end the poll, right?
I can end them. There's just like a few participants left.
Okay.
Great.
Okay, so majority of you guys said cover the upper 2 cms of the vagina if involved, and then extend down. So let's see what the right answer is. The answer is cover the upper 2 cms of the vagina, and if involved, extend down 2 cms below the GTV. Absolutely correct. Very good. So key is, that is one of the most common mistakes, and we're going to talk about that, is how much of the vagina to cover. You should not go all the way down to the introitus. And I showed you there was actually an expert that went down to the anus, right? But it's still there. Covering upper 1/2 of the vagina, just FYI. I'm not sure that that's totally incorrect. The right answer is the upper 2 cms, and if involved, extend down 2 cms past the GTV. But covering the upper 1/2 of the vagina, you're not wrong. Just want to let you guys know that. So the next question, here's the next question. What is the correct way to contour the cervix on a CT scan for external beam radiation? So can we start that poll? A, which is this one right here, B, C, or D?
All of our participants are answering.
All right, we need a little bit more. Should we stop?
Yes, almost 70% of our participants answered. So let's end.
Okay, should we share the results?
Yeah.
Can they? Okay, I'm going to move it over here. So can you guys see? So majority of you guys said A. Some of you said B. 32% said C, and 7% said D. So what is the right answer? The answer is C. So let me explain to you why, and we're going to talk about this, right? So what's wrong with A is it is just the cervix that is being contoured, right? To do intact cervix, whether you're doing four-field or IMRT, you want to cover the perimetrium, right? The perimetrium is just as much part of your contour of your CTV, okay? So That's really important. You've got to cover the perimetrium. This one is covering the perimetrium, right? But it is also not, but it's not covering the uterosacral ligaments. And that's the other most common mistake that people make when they're contouring contouring intact cervix, is that you've got to cover the uterosacral ligaments, okay? What's wrong with this one is it is covering the entire rectum. The only time you want to cover the perirectal area is if there is nodes or if there's rectal invasion. If there's no rectal invasion, you do not need to cover the entire rectum. So the reason why this one's right is that it's covering all the perimetrium, right? And it's covering that uterosacral ligament. Okay, so this is really important. These are some of the most common mistakes that are made when you're contouring intact cervix. You want to cover the perimetrium. You want to cover the uterosacral ligaments. Okay, that's really important. You don't need to treat the entire rectum unless there's rectal involvement.
Dr. Jhingran, we have a
Yes.
question on the chat.
Uh-huh.
Is there a merit in contouring cervix and the parametria separately, or do you do it together?
Okay, so it's up to you. We never contour it together. I think Embrace does it separately, but then it puts it all together. It's up to you. I think it's a lot more work, and I'm going to be honest, it's a lot more work contouring it separately. So we always put it as one contour. So, and it's a good question, and maybe I need to change that question to a little bit different. Again, Embrace has you contouring it separately, and then they make you combine it. It takes a lot more time. When I'm contouring, I don't have that much time, right? Because I'm seeing so many patients, as probably you guys are. So I do contour it together. It doesn't matter. It's just easier for me to contour everything together because in my brain, the uterus, the cervix, perimetrium, the uterosacrals, and the vagina are all one target. Does that make sense?
Yes, it does. It does, because under contouring guidelines, sometimes you see it separately. Right. So I think that probably a lot of people does it that way.
Right.
Thank you.
Excellent question. Excellent question. So now we're going to go to, I'm going to end this, and we're actually going to go to my case. So let's go to the case. And here's the case. And so how do I do it? And again, you guys, it's a good question. We're going to contour, and then I'm going to show you what I've contoured. And just ignore this because I can't figure out where this is coming from. I'm trying to figure this out. Air in the rectum. There we go. Okay. All right. So I'm going to show you how I contour, but you guys can do, oh, there's a raised hand. Somebody has a raised hand. Can you see who has it?
Yes,
whoever has a raised hand, ask me a question. Go ahead. Don't see it. Okay. I'm going to have you help me with that. Okay. So the way we simulate our patients, we actually do an empty and full bladder. You do not have to do that. So we always do an empty and full. So as you can see on my screen, I have a full bladder and an empty bladder. And we do an ITV. So we will contour everything as if it's being treated on both the empty and full. Now, is that the absolute way of doing things? No. Okay. So here's the thing, that is not the absolute way. Most of my colleagues will always contour just on the full bladder. And then what they will do is do daily cone beams to make sure that the patient's cervix and uterus is in the same position and the bladder is full the whole time. I will tell you, we have a very hard time keeping our bladders full, especially if the patient has diarrhea. So I normally tend to treat an ITV unless the ITV is so big that there's such a big change in my uterus, depending on the full and empty, that I'm treating too much bladder, then I will only treat on full. But my standard, or the standard at MD Anderson, and it doesn't have to be your standard, we always do an ITV. So let's just start, and we can start from anywhere, but we're gonna just start, okay? And then we'll just talk about, and again, ask me questions. This is our planning system, so everybody has different planning systems. This is Ray Station, and like I said, this patient was simulated both full and empty. So if I was going to look at this, the level I'm in right now I'm in the level of the cervix, right? Here's my cervix, right? And it's actually almost the level that I showed you, right? So here's my uterosacral ligaments and my perimetrium. So if I was going to do this, and I would definitely do an ITV, so I would actually kind of go over to the empty, make sure that I'm covering everything on the empty as the full. So as you can see, I'm looking at both, and I'm going to contour. And this is my CTV, ITV of the uterus cervix, right? So as you can see, I'm making sure. Now, what am I missing here? Can you guys see that? And you can see this is where that expert probably did. So this is the uterus right here, right? So here, my bladder is right here, but here is my uterus. So if I was doing a true ITV, here's my uterus, right? So I would have to contour that. And I'm going to show you different ways of doing this, but let's just say that we're going to do an ITV right now, and then we can decide if this is the right thing. But so this is pretty much what I would contour on this slice. And you can see where probably that one expert had that, right? So let's go up a couple more slices. Again, here's the uterus, right? So I would contour this if I was doing an ITV, a true ITV. Cover the perimetrium, go over, and then go and cover all of this, right? Now this probably, and you can see here, if I'm just looking at my empty, I'm not covering it completely on my full, right? So I'm going to go down here on my full, and I'm going to make sure that I cover everything, including, again, my uterosacral ligaments, my perimetrium, and everything there, okay? So as we go up a little bit higher, and let's just make it, it's a little bit hard to see, but you can see, again, if you looked at your full and empty, here's your uterus, right? So you're going to go and cover your uterus. And then here, you're going to go to your full, and you're going to make sure that you cover all of the cervix, perimetrium, and the uterus on the full empty. Okay, so this lady has actually a little bit of fluid right here. So you can see that. Now, does it have to be covered? It's totally your decision whether you're going to cover it or not. I am covering it, but it doesn't all have to be covered. We don't know why she had fluid. She actually had fluid because she actually had her ovaries transposed, and there was just fluid left on this. So if we go up a little bit higher, here you're going to just see your uterus, right? So here's your uterus, and you're just going to cover your uterus. Then you go higher, and I think, and this was the one I had a little bit harder time. So here's the last of your uterus. Okay, so this is a true ITV. So let's go down a little bit, and then this one, again, if you're going to do a true ITV.
Dr. Jhingran, you have a question on the chat, actually two questions. Where do you start contouring the perimetrium? And regarding the fact that if you decide to contour them separately, does it add something if you decide to give a boost for the perimetrium and the cervix or GTVP?
Okay, so okay, very good question. So all of this is good. Okay, so one, let's talk about this, a couple of things, okay? And then I'm going to show you how this actually ends up being. But one, do you need to do a boost for the perimetrium? People are no longer doing boost to the perimetrium unless there's still disease left at the time of brachytherapy. So if you have a stage 2A or even a stage 3B, you do not have to boost the perimetrium unless there's still disease left at the time of brachytherapy. And to be honest, people are getting away from actually boosting the sidewalls or the perimetrium because they're putting needles in at the time of brachy that will boost it. Now, if you can't do needles, like I said, the perimetrium does not need to be boosted if you do not feel it at the time of brachytherapy. Now, where do you start the perimetrium? And that's a good question. And what I usually look for is these vessels and where the vessel is. And this is actually a good case because you can really see. And this is where contrast does help. If you put contrast in, it does help you to find out where the perimetrium starts. In this case, you can see it. I would have probably, so this is probably the place where I would start it. is the perimetrium is right here, right? And I probably did, it's too far up. I'm sorry. And so it has some nodes, but you can see where the perimetrium starts. And it's a good question. Where do you start the perimetrium? And I will actually have to get you some true literature on that, because I do, like I say, I look at my contours and figure out where the vessels start and then just contour it. But there is set guidelines on for where exactly to start it, and I will get you that answer. But you can see in this case, you can really see where that perimetrium is, right? And where you stop it. This is probably the last of the perimetrium right there. Probably, and then, yeah, because then it's all nodes. But that's a very good question. So then as you go down, as you go down, you're going to, again, the same thing. If you're doing an ITV, you're going to go ahead and cover whatever's in the whatever's up in the empty and the full. Probably too much there, right? Probably too little there. Sorry, go down. And then now you're actually in the vagina, right? And again, you can see it's not just bladder filling that makes a difference, is also your rectal filling. This lady had a lot of gas. So the question is, how do you get rid of this gas? Now, I would have actually put a rectal tube in and pulled this gas out, right? But you don't know what it's going to be like when you treat her. So it's important to, you know, that's again another reason why the ITB is important. So if we look, okay, so the key thing I didn't contour is a positive node, right? So let's look and see where that positive node was. And here it is, right? Here's your positive node, and we can actually, so it is contoured. I actually did it ahead of time, but there's your positive node. So when we talked about this having a positive node, so that's your positive node right there, contoured. So let's see how I did compared to what I did before. So I'm going to actually, here's my uterus and cervix, right? And I will interpolate it, which I didn't do a great job. And then here is what I contoured before. And I'm actually going to change this to a different color. Let's make it pink. Let's see if that works. So you can see I did a little bit different, right? But you can see where, but the other thing though, it's really important. So as I showed you, I did this, the other thing that's important, we did this on empty and full, right? And I haven't quite finished it, but it's also important that when you're contouring, and I was trying to do everything, I was trying to show you the empty and full, but it is also important to make sure you look at your coronals and make sure that whatever you're contouring actually makes sense, right? So what I normally do, I actually contour on my full bladder, and then I look at the coronal and my sagittal, make sure it makes sense, and then I go and do my ITV. But I'm going to tell you right now. So if I was looking at this case, and so let's just look at this case. So I'm actually going to cone it down. So let's look at this case. And I didn't actually quite finish. So you can see where all the uterus is right there. So I didn't quite finish. And if we really looked at what I contoured before, and we'll take this one out. Okay. So you can see where I have all of this. So in this case, you can see what is different. What is the difference between this contour and that contour, right? I'll tell you what the difference is. I chose, when I actually did this for the expert panel, not to do a true ITV, okay? So I chose to treat this patient on a full bladder. And I will tell you, in real life, looking at this and considering how much of the bladder is being treated by the ITV, I would do the same thing. I would actually contour as if it was not a true ITV. Now I would make sure that I have a little bit of margin on the bladder like I did here, but I would not treat all of this. So I would really do this, and then I would do daily cone beams. Questions, you guys? I know that's a lot to go over, but you can see it. This is what I contoured and submitted as my expert. And this is what, if you've noticed, what majority of people did. Majority of people did not do a true ITV, because as we looked at it, we saw that it was treating too much bladder, and we decided that was not the right way. So what we would do is, if we were doing IMRT or VMAT, we would do daily cone beams to make sure my uterus and cervix, as you can see right here, is in the field. Now, I did treat a little bit more vagina than 2 cms, and Bryce says that you should do about 2 to 3 cms, but I probably do like I said, I probably do about 3 to 4 cms of the vagina, but Embrace does say 2 cms. What is your bladder protocol used for this case in your center? Right. So this is a great question. Our bladder protocol is we have the patient empty their bladder an hour before treatment and drink 1 to 2 8 ounces of water prior to their treatment. Usually we start with 1 8 ounce of water, and if they don't feel full, we tell them to drink a little bit more, and then we do a CT scan, and then we'll do the empty scan. We also do because we have bladder scans, we will do bladder scans before we get them on the table to make sure that their bladder is full, and it's as full as it is during simulation. And that's pretty much if you look at the empty, and I can show it to you, you can see how empty her bladder is, right? Look at it. I mean, this is, and we're going to just take this off, but you can see how empty. I mean, her bladder is completely empty. What happened when the bladder was completely empty? The uterus went down and the bowel came up. So if I have a choice, I will treat with the full bladder because you do treat less bowel. So that's why my contour, when I finally decided to contour it, even though I gave a little bit of margins just so that if it moves a little bit, I do have a little bit of margin, right? But I decided to treat it with a full bladder. Okay. So that was a good question.
Yes, Dr. Jhingran.
Yes.
We have another question is that if you don't have a daily beam CT, then you would recommend for the center to do a true ITV?
Okay, you know what? If I didn't have a daily cone beam, I'll be honest, I would probably treat with an empty bladder in this case. Because now you don't always see this much movement, right? This is actually an extreme movement, and the reason why I use this case was to show you this extreme movement is you don't always have this extreme movement. If I didn't have daily cone beam, in this case, because of how much it moves, I would probably treat this lady with an empty bladder because it would be more consistent and you would not miss your uterus. The other question is, what is my PTV? Is there a standard margin? So I don't have, no, so I always contour with an empty and full bladder. So that is my standard. My PTV is always 7 millimeters. So I do a PTV that's 7 millimeters. And if you can see, it is right here. Here's my PTV of 7 millimeters. How much margin? So this is a question. What is a suitable margin to allow into the bladder? Okay, so that's a very good question. So there's no right or wrong answer. Like I said, we usually do an ITV. This is actually an extreme case. The bladder can tolerate 45 gray, right? The bladder can tolerate even 50 gray, right? The problem is the more dose you give to the bladder, the less dose you can give with your brachytherapy, right? So that's why I did choose not to do that ITV. For the bladder, I will give, good question, I give about a cm to cm and a half margin anteriorly in my CTV. So you can see that's about what margin that is about. I really tend to give about a 1 to 1.5 cm margin anteriorly in my CTV, and then I do that 7 millimeter margin with my PTV. Right, 1 to 1.5, exactly. Perfect. So if you don't have daily cone beam for intact, is it? No, I don't. Okay, so again, this was an extreme case, and I shouldn't have probably shown this extreme case. It's just it was a good case because it was so extreme. Majority of cases don't do this. Okay, majority of cases when you do an empty and full, your uterus doesn't move this much, right? So if your uterus doesn't move that much, then doing an ITV and not doing daily cone beams and doing IMRT or VMAT is okay. So in most of our cases, at this case, I would do a daily cone beam, but in most of our cases, I would not do a daily cone beam because I would have an ITV because usually the uterus does not move that much. Does that make sense?
Yes, I think it does. And thank you for sharing these extreme cases because I think you can also encounter them on your daily practice.
Right. So in this case, I would treat with if I didn't have a daily cone beam, I would treat with an empty bladder, right? And I would make this much tighter, right? And I would not do an ITV. I would do an empty bladder, very consistent, right? And you could still spare all this bowel, right? Because then you're gonna you're gonna contour this, and this will and have the patient empty her bladder every day before she gets on the machine, and then you can still spare all of this with IMRT or VMAT. It's just a little bit better, but so you may treat a little bit of this bowel right here, but you can still spare all of this with VMAT. Other questions before I go on to brachytherapy contours?
I actually have one question. And I
Uh-huh.
noticed that you mentioned when you were contouring the 2 cms of the vagina, that do you use a radiopac marker for your cervix? Because sometimes some people say you need to use it, or sometimes you don't. So for you, what's the use of a radiopac marker?
So it's a good question. Again, I don't. For my intact cervixes, I don't. If there is vaginal involvement, right, I will do an EUA and I will put fiducials in. If there's true vaginal involvement, I will do an EUA and put fiducials in so I know where the lower extent is. I always, which is not here, I always fuse an MRI as well. So I always have, for my patients, I will always have a full and empty and my MRI. And I really use my MRI to help me know what lower extent of the vagina I should go in. So if you can do that, that's amazing. Again, I didn't do that here because I don't know how many people have an MRI. So I do cheat. I do think it's hard to put something in unless you truly put fiducials in. It's
Mhm.
really hard to put markers and make sure that they're in the correct place. So we don't use markers for our vagina. We don't use markers for anything because you just don't know where they are. So yeah, so good question about how do you boost. So in this case, I would do a SIB because there was only one node, right? And it was a really small node here, and that's what Embrace does. So in this case, I would do an SIB of 2.2 gray in this case, right? Because it's less than 2 cm, so I would do a 2.2 gray boost to this while I take everything else at 180 a day. So this will get 55 gray, which is equivalent to about 60, and then your implant gives some dose to it. So, but if any node is bigger than 2 cms, then we do a sequential boost. So if it's a bigger than 2 cm node, then we will give 200 to that node, take it to 50 gray, resim her, and then do a sequential boost. Now, and the key is this, because this will get dose from the brachytherapy, taking it to an equivalent dose of 55 gray, which will give you an equivalent dose of 60 is good. If it's not going to get any distribution from brachytherapy, then you would probably have to give a little bit more, come back and give a little bit higher dose to it. I mean, that's a great question.
Dr. Jhingran, are you using the Embrace recommendations for prophylactic para-aortic nodes contouring?
No. And I did. So like in this lady's case, I would not have treated the parodics, right? And if you saw that 50% of the experts didn't, this is a low pelvic node. So we would and it was one node. So we would just go to the bifurcation of the aorta. Now, if it's a higher node, right? If it was a true, a higher node, if you saw a node that was above the sacral, right here, so it was a higher external iliac node. So if there was a node that was positive here, then we would probably go to L3. But if it's a common iliac, we go to L2. And then if it's positive paraortics, then we go to the renal vessels. But we don't prophylactically treat our paraortics because we have PET scans and we're going to believe our PET scans. But we do extend our fields depending on where that positive node is. But again, Embrace does, there's again no right or wrong answer. And if you saw, the experts did it all over the place too, right? So there's no true right or wrong answer. And I think we really do need to look at that.
Agreed, thank you. And if someone wants to open their mic, they can do it whenever they want. Thank you.
So why don't we, so we're not going to do the post-op because I'm going to come back and talk more about that post-op. So we're going to go to brachytherapy. So I think we're going to skip one question that you have on your thing. So I think the next question you have, we're going to skip. So let's talk about brachytherapy. So I'm actually going to ask you questions first. So can we go to this question? There we go. Perfect. So what type of imaging is used to contour a GTV for brachytherapy? Are people already answering? Ultrasound, MRI, CT scan, or both MRI or CT scan?
Okay, almost 70% of our participants are answering, have answered.
Yes. Why don't we end it? Oh, okay. So basically, nobody said ultrasound. 26% said MRI, 21% said CT scan, and 53% said both B and C. So what is the right answer? So the right answer is MRI. So that's, I mean, and I did ask you a tricky question, but to contour GTV for brachytherapy, the only way you can do it is with an MRI. Because the MRI is the only thing that's going to show you the GTV. The CTV, which I'm going to show you in a minute, will not show you GTV. So you cannot, if you're using if you're using a CT scan to contour your brachytherapy, you cannot contour the GTV. So the next question, what is the average height of a normal cervix that should be contoured for HRCTV for brachytherapy? 2 cms, 3 cms, 4 cms, or 5 cms? And let's get more than 70% answering. You guys all know these answers. And it's okay, nobody knows who's answering what. So if you're wrong, you're wrong. We only got 50% right now. Okay, we got almost 70. So why don't we end the poll? The poll is not pop up. So I think somebody's having a problem with their polls.
Okay.
Yeah, but we got 70%. So we have to figure out what's going on with that. So 40% said 2 cms, 30% said 3 cms, 25% said 4 cms, and 5% said 5 cms. So this is important. And this is actually something that I need, if you get nothing out of this talk, the one thing I need you to know is the normal height of the cervix is 3 cms. So if there's no uterine involvement, that is a very important distance to put when you're contouring. Your cervix should not be longer than 3 cms. And we actually will measure it on our scan so we know how high to go up. So this is actually probably the most important, if nothing else you get out of this talk, remember that the normal cervix is 3 cms. Okay. All right, so let's just talk a little bit. I'm going to do a little bit of slides, and then I'm actually going to talk about how to contour. Okay, so we've gone from 2D to 3D to 4D, right? So we've done image-guided brachytherapy. Why have we done that? There's multiple reasons, right? One, we can reduce the dose to the organs at risk because we can actually see the organs at risk. We can dose escalate. And what are the imaging that you can use? You can use an MRI, you can use a CT, you can use ultrasound, and you can actually use ultrasound, okay? But the important is that image-guided brachytherapy really defines the disease, but it also defines the normal tissues, and it actually helps you shape the dose to the area that you want to treat. So this is the difference, right? For plain x-rays, you could not see the tumor, and you really couldn't see the normal anatomy. So you were really just, doing by what you saw were points. And there's nothing wrong with it. We have great data and patients have survived and we cured cancer, right? The advantage of 3D is that you can actually see the normal anatomy and you can see the tumor. But here's the difference between CT and MRI. CT, you cannot actually see the GTV. And that's what it says. You can see on an MRI, and it's got to be a T2 MRI, you can see the GTV. CT, great for you to see the uterus and where you think the cervix is, but more important, it's actually very good to see normal tissues like the small bowel, bladder, and rectum. The MRI shows you everything much clearer, including the normal tissues, but it's also harder to get. So what are the things that we want to contour, right? And this is the JEC Gastro recommendations. They recommended on MRI, but I'm going to tell you, we don't use MRI on all of our patients. In fact, majority of our patients are contoured on CT. We will get an MRI the 4th week, and we look at it to help us contour, but majority of our patients, unless we're doing needles, do not get an MRI. So I need you to know that. So on an MRI, GTV. So GTV is only visible on the MRI. But you can contour the HRCTV on a CT scan. And that's what we are contouring now, and that's what we're dosing to. So what is the HRCTV? It's the GTV, which on a CT scan, you have no GTV. So the HRCTV on a CT scan is the cervix plus the gray zone, which is usually the perimetrium. But you only include what you can feel at the time of brachytherapy. So the HRCTV is the entire cervix and whatever you feel at the time of brachytherapy. So if there's no perimetrial involvement at the time of brachytherapy, you're not going to contour it on your HRCTV. Okay. If there's no vaginal involvement at the time of brachytherapy, you're not going to contour it on your HRCTV. If there is, then you're going to contour it. Okay, that's important. Then the IRCTV, which we're not going to contour today, and which we actually don't, but Embrace is actually asking you to, is the HRCTV with some expansions, 10 millimeter margin, restricted to 5 millimeters anterior and posterior. Okay, and then the normal tissues. So here is the GTV on an MRI, the HRCTV, which is the entire cervix, which the length, which I told you guys, right? 3 cms. This is 3 cms long. That is how tall, that is the length of your cervix. You got to know that. And then the intermediate risk CTV. So as I've said, the CT scan will overestimate the size of your cervix compared to the MRI. Okay. CT scan, though, is really good in helping you contour the bladder, the rectum, and the small bowel. And that is important. And this is just an example of the difference in contouring between an MRI and a CT. So this is the MRI and this is the CT. And you can see the CT definitely does overestimate, but that's okay. Like I said, we don't normally do CTs on majority of our patients, but you do need to realize what are the limitations on a CT versus an MRI, okay? That's really what I wanted to show you, the difference between the limitations on a CT and an MRI. Okay, so let's ask the last question for the day. What is the correct way to contour? And we're gonna go through this, right? So I don't need, and again, answer the question. It doesn't matter because this is a learning thing, right? So what is the correct way to contour the HRCTV on a CT scan for brachytherapy? A, B, C, or D?
So I know a few people had problems with their Zoom polls. We're working on it.
Okay, so we're at 57%, so we'll just go ahead and, so 19% said A. Majority of you guys said 40 said B, and you guys are all right. 4% said C, and 32% said D. So the answer is B. And the reason is because and you know what I didn't tell you. So you know what? So you did it right, but I'm going to tell you. So at the time of brachytherapy, you didn't ask me, right? And I didn't tell you there was actually no perimetrial involvement, right? So if there was no perimetrial involvement, this is actually the right answer. Now, if there was perimetrial involvement, actually none of these are correct. I would have probably still gone in a little bit tighter, but this is the right answer. So good job, everybody. So let's then look at a contour. Let's do a quick contour. I know you guys are running late, but let's do a quick contour. So this is, again, I have it on this is not my planning. This is not what we plan on. This is not what we contour on. Actually, our goal is eventually to do this, but right now we are not. But this is, again, my race station because I wanted to make it easy for you guys. So this is a lady with just normal, it was a straightforward stage 2B with no perimetrial involvement at the time of brachytherapy. And you can see here's the ovoids, here is the packing, and here's a tandem. So if we went to the center of the ovoids, of the system, here's my tandem, right? So what do I do? What is the first thing I do when I contour? The first thing I'm going to do when I contour on this, I do measure, okay? take my Zoom off. So I do measure, and actually I will have my either my physicist or my dosimetrist measure for me, but I will measure my 3 cms, and I leave that 3 cms up so that I know what the height is going to be when I contour, okay, and how high I should go. So that's pretty close. So I leave that up there. Well, I usually do. For some reason, it's not working, but that would be what I would do, and then I would measure. Okay, so I would leave that there and make sure that I had that there for me to know what to contour, how high to go up. Okay, hoping that stays. Okay, so and then again, this is where you have to 100% have to look at your coronal and your sagittal. Okay, and I know this isn't quite as clear as I would like it to be because they transferred it from my planning CT to this. So I'm sorry that it's not as clear, but I thought this would be an easier way of doing this. So again, I do apologize that it's not as clear as I would like, but it should work. So what do I start with? And this is again an important thing. What's the easiest way to start? What I normally start with is I normally start with my normal tissues. So I would start with my bladder and I would start with my rectum, right? So I would go ahead and start with those first because that always helps me figure out what else is left for me to contour, right? So I would start off with the bladder and the rectum. So just letting you know that's really what I would do. And there is a Foley in this patient's case, so you can see. So that's a key. And I think that's where half the problem is to make sure that what did I do? I did something wrong. Sorry. I think I contour the rectum. Wrong colors. Okay, let's try this again.
Dr. Jhingran,
Yeah.
we have a question on the chat.
Yeah, while you do that, well, I totally messed this up. Yes.
Do you add contrast in your packing?
So we have contrast. Okay, so we have a wire in our packing, and that's why you can see that. So that is actually a wire that you can see the packing. Now, if I was doing an MRI, I actually will use ultrasound gel.
Okay.
Okay, and that actually helps you see it on the MRI. But we have wires on our packing, so you can see our packing. It's a little bit distracting though too, because we do have a wire, so you can see that there is some distraction out of it. So I would first contour, like I said, I would start with my normal tissues. And I'm not going to do this because it will take forever, but that's what I would start with is my normal tissues, because that will help me contour the rest of everything else that I'm going to do. And you can see in this case, it's going to be a tricky case because there is bowel right above my bladder, right? So what would you do a little bit different, or what would you do before planning this case and before you even, if I saw this, what would I do? What would you do to help with this? Anybody? So you know what I would do differently in this case? I would fill up my bladder more because it would push all this bowel away. Okay, so I would treat this patient with the full bladder. So I would put 200 cc's into the bladder because that would push all my bowel away. So just letting you guys know, that's what I would do a little bit different in this case. So I would CT her with the bladder full. Does that make sense to everybody? I mean, just looking at it, that's what I would do. So I'm now contouring, so I'm above my ovoids, and these are actually Genevas. So you can see the ovoids well. So I am right above the ovoids. And like I said, that's where the bladder or going ahead and already contouring your bladder helps. And like you have to look at your sagittal and your coronal to make sure that you have everything contoured correctly. So ask me questions as I'm going up, you guys. Yeah, in this case, I would 100% fill my bladder up because that's going to push this bladder on this bowel away.
So you would decide how much to fill the bladder, like on a 1-by-1 case, or do you use a protocol for a bladder for brachytherapy?
No, so a lot of people do. We do one by one case.
Okay.
Because, sometimes filling the bladder makes it worse. A lot of people do fill it up consistently at 200 cc's. I will tell you that filling it up completely consistently at 200 cc's every time is not always necessary.
Okay.
I will always, and then there's sometimes where I will change my bladder filling for each brachytherapy depending on the dose to the bladder, the dose to the bowel, right? So because that's the advantage of HDR, right? You can change it every time. So I will change it if there's too high of a dose to the bladder, or if there's too much high dose to the rectum by filling the bladder, but by filling the bladder, it changes the dose of the bowel. I will change my filling every time.
That's a great tip, because I think sometimes we use like a standard protocol for the bladder. So thank you.
Yeah, no, 100%. I will change it. One of my cases recently, I changed the filling and this is actually the one I drew for you guys. I will change my bladder filling for each fraction because it really did make a difference. So one I did 200, one I did 100 because the bladder was just getting too hot or it was pushing it too posterior. But not filling it was treating the entire bowel. So there was one where I didn't treat it, I did not fill it, and the entire bowel got a higher dose, but the next fraction it didn't, right? So it's a different dose every time.
And we have a question on the chat regarding this. Do you use a contrast for your CT in the bladder for the filling?
So I don't, but I've seen some people do, and I think it does make a difference, right? I have seen some people do it, and that does help you contour the bladder. We haven't, but like I said, most recently I've noticed that. So I think I will probably start doing that to help me know where exactly the bladder is. But you can see, look, this is all bowel here. This is where in this case 100% filling the bladder will make a big difference. So I'm kind of guessing, and I will come back and fill all of this, you guys. But so let's go back and measure. So I'm not quite there. So I actually will have to go. So you can see that I actually need to go a little bit further up. So I probably need to treat this. And this is what it is really important. And my dosimetrists know how to keep that measuring tool up, so I know exactly how far to go, how high to go up. But I know we're also running out of time, and I know everybody has things to do. So questions or things I can answer while I'm finishing this up. So I would come back and I would look at my sagittal. And you can see from my sagittal, if you go here, let me show you. So from my sagittal, I do need to go a little bit more posterior. So you can see I didn't go quite as much as posterior as I should. So I definitely need to go more posterior. So I would go back to my axial. That's why you have to go and look and make sure you look and make sure that you're covering and that's why it's so important to look at everything when you're doing it, your coronal, your sagittal, everything. And then I would interpolate too. So
Okay, we got a great question in the chat. So
yes.
if you don't have an MRI pre-treatment, do you recommend to include some part of the uterus in the high risk CTV? I think this is something that happens because not everyone has an MRI pre-treatment. So what do you think, Dr. Jhingran?
Yeah, I think you should include some of the uterus. Definitely. I think you should definitely include some of the uterus in your high risk CTV then. Unless it's a true exophytic lesion, then it depends on what the lesion is. If it's a true exophytic lesion, the uterus probably isn't involved, right? But if it's not, if it's an endocervical lesion, then yes, the uterus is definitely going to be involved and you should definitely include it. And I probably went too posterior here, right? Good question. All right, you guys, what other questions do you guys have? I know you're running out of time and I'm.
Dr. Jhingran,
Yes.
a question for you. How do you contour the vagina in the case of vaginal residual disease after external beam radiation therapy?
Ask me that question again.
How do you contour the vagina in the case of vaginal residual disease after external beam radiation therapy? So I think that you go ahead and you finish the 25 sessions of the external beam radiation therapy, and that patient is going to brachytherapy, and you can still see there is vaginal residual disease. How would you contour that on your CT?
So then you would go below, but the problem is the ovoids would not treat that, right?
Mhm.
So that's where you would have to use cylinders or needles, but then you contour, and then you would go lower and, make sure you contour the vagina. But your ovoids would not be able to treat that. You would have to use a cylinder. Other question, you guys.
As you go higher and uterus start bordering the cervix, how do you shape your transition into the uterus?
Right. So this is, so you can see where, as you can see here, and actually I went to way lower in the vagina just to show you how you would contour the vagina, but I would not have gone that low. But as you can see, I'm almost there. So, and if I measure this again, so please don't treat like that. Don't go that low. I just was showing you how I would treat the contour the vagina, but please, 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 please don't do that. So I'm almost there, right? So I would start coning it up here, and then you start doing your cone, right? Then you start coning it up, and that would be your cone, and that you'd be right about. So the only thing I think I would do a little bit different is I'd probably go a little bit more posterior here. So you're right in the uterus now. Just be a little bit more consistent. But does that, there you go. So that's where that 3 cms comes in so importantly. All right, you guys. Other questions before we end this? So conclusions. Let's just end with the conclusions.
There is just one last question in the chat. Is regarding vaginal involvement. Are there other options if a tandem and cylinder applicator is not available, or interstitial brachytherapy?
You know what? I don't know, because I don't know what else you would do. Somebody asked me, and somebody did ask me if they don't have cylinders, right? So I guess the other option is you use the tandem, and then you put packing in the vagina so that you can at least separate the tandem from the vaginal wall, and then load the tandem. Now, I've never done that, so that's a very good question. But I think that could be the other option, right? Is putting the tandem but using packing so that the vagina is not getting the full dose, because that's what the cylinder does, right? The cylinder moves the vaginal wall away. So if you could pack in the vagina there, so you're moving it away from the tandem, and then you load the tandem. That's the only thing that I can think of. And I think that's probably what would work the best. I like that. Yes, I agree. All right, so you guys, conclusions. Common contouring errors for intact cervix. So key is you got to contour your uterosacral ligaments. It's really important. You got to decide when to treat the ITV versus just treating on empty and full. And I did show you an extreme. I should have shown you one in between, and maybe the next session, because we won't have so much for the endometrium. I may show you one where there's not much of a change, and I will do that next time, okay? The length of the vagina is really important on how much to treat. Key is what we already talked about, how much of the nose to treat and what should the top of the border be. And I don't think there's a right answer for that. And how much of the sacral nose to treat. And we did not talk about that. And I know they talked about that in your previous session. So I'm not going to say a whole lot, but you guys can ask me questions about it next time. We're going to talk about post-op next time, but let's talk about brachytherapy. Key is not to over contour. And, I was contouring like this. I do look at my sagittal and I do look at my coronal. So that's really important. Your coronal is going to help you with your width. And that too, which I did not show you, is you also measure your width by your physical exam. So if your physical exam shows you the cervix is only 4 cms, then your width should not be more than 4 cms, right? That's important. You got to know what your width is as well as your length, right? So the length is always going to be 3 cms unless there's uterine involvement. The width is going to be whatever you feel. So if you feel 5 cms, contour 5 cms. But if you feel 4 cms, then contour only 4 cms. And that's the other thing I do, is I measure my width, which I didn't do here, right? Know your disease at the time of brachytherapy. That's important, which is what we just discussed. How much vagina to treat. And then contouring normal structures. It's really important. You got to know where the bowel is. You got to know where the sigmoid is, where the rectum is, and you got to contour that. And it really does take time. Contouring really probably takes more time than planning does. And you got to do the contouring correctly. And I think that's it. Thank you.